I'd like to welcome our next speaker, Richard Benjamin. Richard has braved the volcanic ash and flown here early. He's a psychiatrist and practicing psychotherapist who works mainly in the adult public mental health service in Tasmania. His main work is focused within the community. Richard's particularly interested in the serious mental health repercussions of childhood trauma and the systemic response to this group, as well as more general systems responses to mental illness. Richard's talk comes in two parts. The first, which we'll hear today, trauma-informed care and practice, engaging the left and right hemispheres, and the second tomorrow at 10 a.m. So Richard, is it one hemisphere at a time, or... Thanks so much. Let's welcome Richard.
There goes my first line. I think I got the last plane out of Tasmania on Tuesday, and I was going to reiterate some of Deborah's comments from earlier this morning about being privileged to be here and be invited to speak to such a great group of people on such an important topic. This is a paradigm shift, and I think we need to be ready to address it for probably 2 or 3 decades. I think I'm here on the back of a talk that I gave a couple of years ago in Sydney, a trauma-informed care talk on seclusion and restraint. And I think I got to that because I have dual training. I have training as a psychiatrist, and I have training in a very contemporary form of intersubjective psychotherapy, the conversational model. The conversational model tells us what happens in between. And I've really only got one message that I'm going to try and deliver over the next couple of days, and that is that we are created in between, we can be damaged in between, but we can be restored in between. And I'm going to say that in various different types of ways, but I'm going to say it over and over again. I'm glad that everything's up on the website. I do have a lot of details. I'll also have some photocopies here tomorrow if anybody wants a hard copy of the talk. I've just got 2 caveats to mention before I get going. I am going to talk about one particular way of addressing things, but the area we work in is inordinately complicated, and there is a very great number of ways of addressing things that are all very valid. I'm just going to talk about one, but I'm just going to acknowledge that things are very, very complicated. I'm going to make one final qualification, and that is I'm a doctor, and inevitably, unconsciously, I'll use the word patient from time to time. I apologise for that. When I use the word patient, I tend to mean someone who suffers rather than someone who suffers in the context of a patriarchal relationship. So I'm going to start with a bit of a summary, and it goes like this. People presenting with mental health problems do so for many and varied reasons. Schizophrenia and bipolar disorder and major depressive disorder are conditions that often have significant genetic and biological components, and these conditions are traumatic in and of themselves. Other people in mental health services present with a very wide range of traumas, suffered at many different ages, and these traumas may frequently play a significant or even a central role in the way they present to mental health clinicians. Some patients with psychotic illnesses have suffered with trauma as well, and then both are important. Today I'm going to focus on trauma and not the psychotic conditions, but I don't want to undermine the significant suffering people with psychotic conditions go through. Now, much has been written about trauma and its effects, but this knowledge is very complex, and I don't believe it's very well widespread or well implemented, particularly in public mental health services. People have been talking about stories this morning, but I'm going to talk about things a little bit differently. Sometimes both the patient and the clinician are unaware of the connection between the symptoms and the trauma, or they underestimate the significance of this connection, and implementing this knowledge is obviously going to be very, very helpful. So my talk comes in 2 parts. The first part, how we're put together and how we're taken apart. I'm going to talk about emotional interchange or affective interchange between people via some very interesting studies that look a little bit peripherally involved. I'm going to talk about Colin Trevathan and Alan Shaw, who I think have an enormous amount to contribute. I'm going to talk about some of the statistics and sequelae of abuse and trauma. A lot of it's already been covered. I won't spend very much time on that. And I will finish today with a story, a case presentation. Tomorrow I'm going to talk a little bit about some trends in Western culture more broadly that affect the way I think we do things in mental health services. I'm going to talk and shamelessly promote the conversational model of psychotherapy because I think it's a wonderful and very helpful way of seeing all sorts of things. I'm going to talk about some of the history of psychiatry and how it's helped to highlight and diminish trauma. And I'm going to talk about looking at affectively informed, trauma-informed care. There'll be two more stories tomorrow. Now, I'm going to talk about what happens in between, but I'm going to start with what happens when you try and observe emotion and affect, and what better way to start than two of my favourite television shows. Popular culture. I've got to think why this is becoming, why people watch these shows, because they're very frequently on. Lie to Me, that many of you might recognise this as the character Cal Lightman in Lie to Me. And Lie to Me is a show where Lightman runs a scientific bureau aimed at detecting affect and emotion, and particularly for judicial services, he uses this science to look at the ability to detect a lie. Now, obviously I've showed you this slide for another reason. This has nothing to do with my talk today. This is because Simon Baker comes from Tasmania. He spent his two most formative years in Tasmania. He was born there and he left when he was 2. But Simon Baker plays Patrick Jane, the mentalist, and he also stars in a show where his job is to look at the non-verbal and not the verbal communication between people. So these shows are about reading people. They're about looking at faces, looking at body language and looking at non-verbal cues. Are they valid? Well, yes, they are. Lie to Me, excuse me, is based on the work of Paul Ekman, who is an American affect researcher who's been studying these things for 40 years. And his mentor was Sylvan Tompkins. And Sylvan Tompkins is really the originator of affect theory, wrote a series of books in the early 1960s. And Tompkins wrote this: affects or emotions are innate, hardwired, and powerful motivational forces. He felt that we organise our lives to maximise the positive emotions and minimise the negatives. And these are the standard types of affects or emotions that have been described in the literature: joy, excitement, so on. Ekman has studied these expressions for many, many years in multiple cultures, in psychiatric patients, in normal patients, in children. And he believes that there are over 10,000 possible ways of putting our faces together. And he wrote in 1976 or 1978 the FACS, or the Facial Action Coding System, which is the first atlas of the face that in a very objective way describes how we can appear to other people. I don't know how that works, whether people can see that. This is a sort of scientific description of the affect of contempt. You can see that what happens in contempt is that one side of the mouth is raised and it's asymmetrical. Can you appreciate that? And contempt is something that I will repeat over and over again in the next 2 days, and it's a term that I think is very important. It's one we don't really talk about very much in mental health services, I think. So Ekman's most famous, as I said, for identifying a lie. But he didn't start out to do this, and this is going back to the 1960s. And what happened was psychiatry trainees were asking him how to help facilitate safe discharge when they were reviewing people who'd been depressed. And what happened was a patient was depressed, went home, nearly took a life, didn't, and what he did was fortunately there was a videotape taken of the session just before she was discharged, and he reviewed it and reviewed it and reviewed it. It took 100 hours for him to do it. He slowed it down, and what he found was that there are these little leakages of affect that flash unconsciously from one person to another, and that we can't perceive consciously. And he coined the term micro-expressions for these things that last less than a fifth of a second. Now, that's real science, and what they purport to show in the movie or in the TV shows is that you can sit back and you can watch it and you can comment on it. Now, what I'm going to talk about is a little bit more complicated. It's the next step. So what I'm going to show is that emotional interchange or affective interchange between people is much more important in how they're put together. Most of this work about this comes from infant studies and psychotherapy studies, but I'm going to go a little left field first to look at a couple of other studies. So I'm going to talk about suing surgeons. You're probably not expecting that today, but I'm going to talk about it just very briefly. So you would think if you're setting up a study to look at how frequently or why surgeons get sued, you'd start to think about how many people died, what their infection rate was, those sorts of things. A very clever psychologist by the name of Ambati decided to have a look at the affective interchange between the surgeons and the patients in the office-based meetings outside of the surgery. So what they do is they got two groups of surgeons, those that had been sued twice or more and those that had been never sued, blinded them to the assessors. And what they do is that they audio taped the interactions. They only used 40 seconds for each surgeon. It was the beginning of the session, the end of the session, 2 times for each surgeon, and just his voice. They can do something technical to take out the high frequency sounds, which gets rid of the words so you don't know what they're saying. What you do is you rate them on warmth or hostility, and simply in looking at warmth and anxiety versus hostility and dominance, you can tell which surgeons have been sued. So it's more related to how the surgeon relates to the patient and what actually happens in the operating theatre. Gottman is an American relationship researcher. He studied married couples for about 30 years. He's done very similar things in looking at affective interchange between couples. Looked at the same affects that I mentioned before, added a couple of his own, added some strange things like he's got a jiggleometer under the seat, so how anxious you are, how much your seat moves. And he can predict with 95% accuracy which couple will be together in 15 years and 90% accuracy after 3 minutes. The most important thing about that for me is that the most telling component of this is about contempt. You need 5-to-1 positive to stay together for more than 15 years, and the most important thing is contempt. I'm going to talk about contempt, which is the opposite, I think, of respect a lot. I'll try and bring this slightly into our field of practice now and talk about a 2006 study, which is a review of a famous study done in 1985, which was done initially to look at whether CBT and IPT worked in comparison to imipramine, a standard antidepressant. What happened at that time was it was shown that the psychotherapies and the antidepressants all work roughly the same for moderate depressions, and they reviewed the study in 2006 just analytically to look at what happens when you take the person to the psychiatrist and you treat them as a factor, not looking at the individuals but just taking them as a variable. So I won't go through the numbers, but basically what it shows is that the effect of the psychiatrist is greater than the effect of the medication in both self-report and objective measures. That is, the effect of the psychiatrist is equal or greater to than the effect of the medication in treating moderate depression. A little bit more staggeringly, a third of psychiatrists were better with placebo than another third were with pills. I'll leave you to draw your own conclusions, but it's something to do with us as treating agents. Now, the final one in this group that I'm going to mention, which is a little bit more worrying, this is a study about junior medical officers and a time and motion study about what they do. It's actually in this city and it was done 3 years ago. And I must say, I don't think it's psychiatry people, it's general medical people. But it showed that if you look at a junior medical officer's day, and a junior medical officer is anyone who's not a consultant in this study, they spend, it's actually less than 21% of the time of their day, but less than 15% of the tasks they do are actually in clinical contact with patients. They spend much more time in paperwork, talking to other colleagues, and going to the loo.